Our speaker tonight is Dr. Olga Brawman-Mintzer. She's a researcher at the Roper St. Francis Healthcare Research and Innovation Center, heading clinical research in depression. She is a tenured professor of psychiatry at MUSC. During her tenure, she served as medical director for CNS research and business development for the Clinical Innovation Group, MUSC Foundation for Research Development, and is one of the leading mood and anxiety disorders researchers. She was a senior visiting scientist at National Institute of Mental Health, Division of Services and Intervention Research. Olga also serves as a staff physician at the Ralph H. Johnson VA Medical Center. She has earned her BS and medical degrees at the Hebrew University. I'm not going to pronounce that.
Hadassah.
Can you say that?
Hadassah.
Hadassah, okay. Hadassah Medical School in Jerusalem, Israel. She went on to serve as a postdoctoral research fellow in immunology at UCLA. Following residency training in psychiatry at the University of Miami School of Medicine, she completed a 2-year clinical research fellowship at MUSC in the Department of Psychiatry. This double postdoctoral training, both in basic and clinical research, has allowed her to successfully bridge the barriers between basic and clinical research. Olga has published extensively in peer-reviewed journals and textbooks and lectured around the country and abroad. She has been continuously funded both by federal and corporate sources and has developed and leads large national research groups in the conduct of complex multi-million projects and developed and oversaw new programs. Olga and her husband, Dr. Jacobo Mintzer, live on Isle of Palms. They have 2 adult sons, Jonathan and Adam. And take it away, Dr. Mintzer. It's so good to have you here. Thank you.
So thank you so very much for having me. I'm really privileged that you've invited me to speak. It's a very timely topic, particularly during the times of a pandemic. But talking about depression, I think, is vital at any time. So what I would like to devote some time today to talk about is depression, but in the context of what happens to people who do not respond to treatment, which is a very common problem that we psychiatrists encounter. Most people who suffer from depression are not treated by psychiatrists, by the way. The statistics show the majority of people who suffer from depression are treated by primary care physicians or other specialties like OBGYNs. What we see as psychiatrists is when treatment doesn't work. So we are the referral source for people who struggle despite the efforts of the primary care doctors and other doctors and clinicians in the community. So as you mentioned, let's start. I wanted to start with just giving a little bit background before we move into the topic of treatment-resistant depression, and let's talk a little bit about depression in general. People ask me very often, doctor, it's, stuff is going on in my life, pandemic, issues of work and family stressors, financial stressors. I feel down. Is that something that I need treatment for? What is it? And what I tell people is that feeling sad or down once in a while is part of our normal emotional experiences. However, if you're experiencing feelings of sadness, helplessness, feeling blue most of the time, and when you get to the point that you feel that it affects your day-to-day functioning, that getting up and going and doing the things that one would like to do or has to do is getting harder and harder, that's when we start talking about clinical depression. Now, clinical depression is a more severe form of depression, and professionally we call it either major depression or major depressive disorder, or MDD. Now, as you're aware, we create definitions and criteria for almost every psychiatric disorder, the very famous DSM, which is the book with all conditions, psychiatric conditions, their definitions and criteria. Now, just as a side, it's based on consensus. So really there are a bunch of people, psychiatrists, that every so often get in the room over a long period of time and create those criteria. Not all of them are based on biological changes that happen. They're based on how frequently symptoms occur, like in clusters. And those findings are based on what we call field trials. So thousands of psychiatrists receive questionnaires to see if they all agree on creating criteria for a particular condition. The same goes for major depression. And the definition of major depression has not changed that much from one DSM version to another. Right now we are on DSM-5. This is the most recent one. And the definition of depression calls for the presence of 5 or more symptoms from the list below that I will go over that happen most of the day, nearly every day, for at least 2 consecutive weeks. That's the minimum. And the major part of what constitutes MDD is the presence of either depressed mood or loss of interest or pleasure in all or almost all usual activities. Because there will be people who will come and say, well, I don't know if I feel down or sad, but you know, doctor, I just don't feel like doing anything. I don't enjoy, and I don't feel like doing anything. And interestingly enough, there is some differential with these complaints between men and women. Men would tend more to endorse the latter, the lack of interest or enjoyment. Women more often will describe feeling of the sad and depressed mood. But that's not enough to meet the criteria by the DSM. We also see in people with depression presence of physical symptoms. And this is the list from 3 to 9 that is on this slide. And that includes symptoms like changes in appetite and weight, either up or down, changes in sleep, again, either sleeping too much. Some people say that they just would stay and sleep in bed, you know, for hours, or not being able to sleep, primarily what we call middle or late insomnia. So people with depression will fall asleep, but they will either wake up multiple times or wake up too early and won't be able to go back to sleep. People also may feel either restless or physically slowed down, like made of lead. They would endorse feeling tired, fatigued, dragging. Very important feeling, the feelings of either worthlessness or guilt that is excessive. People will complain very often about problems with concentration, focusing, and memory. They have a hard time making decisions. And the really symptom that creates medical emergency in our field is the presence of recurrent thoughts of death and suicide. So you have to experience one of the first 2 symptoms and to have a total of 5 with the rest from the physical symptom list. And that's what constitutes major depression disorder. Now, most cases, the symptoms last, of course, longer than 2 consecutive weeks. Now, what's interesting is, and why is it important to talk about depression? It's very, very common. At least 16 or more percentage of US adult population at some point of their life experience depression that would meet the criteria for major depression. So again, something quite significant. Women are more affected than men, almost double. And the issue that, again, is so important to talk about, even in people who are treated for depression, and many are, those people will experience more than 1 episode in their lifetime, and very often 4 or more. So for the most part, people who have MDD, who have major depressive disorder, will experience more than 1 episode of depression. And that's what we call that it's recurrent. And in majority of people, that's what will happen. What is important, and it will be the theme of what we're talking about today, is that yes, people do respond to treatment for targeting depression. And we're talking in this particular case here of mostly antidepressant treatment medications. The percentages are good, but are not amazing. So around up 45, 55% of people who are treated with first-line antidepressant, the first treatment that they receive, will respond. It's pretty good, but not good enough. But for us, the threshold and of what we would like to see as clinicians is not only just responding or feeling better, it's getting to the point that you have no symptoms at all, what we call remission. And achieving that is a bit more of a challenge. What we call remission or lack of symptoms of depression, people say, I feel back to normal, doctor, happens in 30, 35% of people, which again is not good enough. Depression is a significant condition, is actually not only because of suicidality, it is leading to many concomitant conditions. Some of them are very, very, very well known. Alcohol or drug abuse. Anxiety is extremely what we call comorbid, co-occurring with depression. In very high percentage of people, we will see both. And it doesn't mean that it's one condition. People can be depressed and anxious, or just anxious and not depressed. But the combination happens frequently and is harder to treat. It affects every aspect of people's life. It leads to significant disability on par with cardiac disease, with diabetes, and other chronic medical conditions. Work, school issues, family problems and functioning, relationship difficulties, social isolation. Suicidality, as I mentioned, is extremely significant. It's preventable, but if not, it becomes a very, very serious issue. Mortality from psychiatric disorder is occurring sometimes at alarming numbers. But it's not only that. We see very often in younger population and that suffer from depression, things like self-mutilation, cutting. It's just almost trying to get rid of the internal pain. And from medical point of view, there is a lot of research to show that the depression affects negatively medical conditions, heart disease, for example. So it is a disease. It is a disease with significant consequences. It is a disease that needs to be treated. Now, I don't want you to to delve too much into this slide or memorize that slide, but I just wanted to show it. It's taken from a medical publication to show the reason for depression. And you see from that slide that it's really complex biological and an environmental, as my kids would say, I'm Jewish, mishmash of things. It's genetics, it's changes in various neurotransmitters in the brain, it's stress, stress hormones that we release affect mood negatively, and some treatments in the past, and there were studies done were targeting the stress system, which, if you've heard of steroids, cortisol, this is the chemical that is being released. It's not good for the body, although important, but again, excess of stress is very detrimental and can lead to depression. We know now that things like inflammation can, in the brain, lead to depression, and of course, genetic influences. So this is this con of all these things together that affect the brain cells in areas that affect mood that can lead to depression. It's not one thing. Now, what should we do? If people complain and feel that something is not right with their mood, that they feel distressed, that they feel negative, that they feel sad, that they feel depressed, can't stress it enough, you have to see a professional. The best way to start, and probably the most economical and the most timely, is to see your primary care or other clinician that you see on the regular basis. And OBGYN for women are sometimes taking on the role of GPs. It is really important, and again, we are consumers as patients. The physician should do a full medical, physical examination like with any other medical condition, through interview, through lab work, because, particularly with first episodes, because there are medical conditions that can masquerade as depression. And I know that it's quite well known, thankfully, with education to people, that, for example, thyroid condition, low functioning of thyroid, can lead to symptoms that look like depression, fatigue, negative feeling, problems with sleep, appetite, but even things like anemia, low blood count, can lead to symptoms that look like depression. Now, if depression is diagnosed, or there is a suspicion by a clinician, preferably one should be referred to a psychiatrist. But again, the world is such, and clinicians, primary care doctors in particular, know how to start treatment. So and we try to educate them, and many of them are quite versed in beginning treatment for depression. There are many treatments that are available, and the most, and I'm a physician, but the most kind of immediate and shortest way to improving symptoms is through medications. And most clinicians will start a person with complaints and diagnosis of depression on antidepressants. And there is a list of the classes of antidepressants, and I did not want to go to excruciating details. Some of them will be familiar to many, what we call the SSRIs. You've heard of Prozac, you've heard of Zoloft, you've heard of Lexapro. Those are the brand names of the antidepressants. Most of what we call the SSRIs are now generic. They're very inexpensive, and they're widely prescribed by primary care doctors. The other group is SNRIs, that's serotonin norepinephrine reuptake inhibitors. And what it means that it affects chemicals, neurotransmitters in the brain that function and transmit information in brain areas that are responsible for mood. You may have heard of Effexor, venlafaxine, or duloxetine, also Cymbalta. These are examples of SNRIs, another family of antidepressants, and the first three are probably the most popular among primary care doctors to start. are what we call norepinephrine dopamine reuptake inhibitors. You may have heard of bupropion, Wellbutrin. This is one and the same. This is an example of this medication. And there are other medications from, some of them are older, like what we call the tricyclics, some monoamine oxidase inhibitors. There's a group we call atypical antidepressants. There are the newer ones. They kind of don't fit specifically the 1, 2, 3 groups. And also a group of medications that are used for people who have psychotic symptoms. They're called atypical antipsychotics. We'll talk about them in a little bit because they play a role in treatment-resistant depression. Now, of course, again, as I mentioned, I'm a physician and worked for many years in research with medications or new medication treatments. But psychotherapy, talk therapy, is a very important and well-researched approach to treating depression. But it's not any talking. I mean, it's very good to seek counsel and supportive therapy, but there are very specific techniques to dealing with depression, and cognitive behavioral therapy or interpersonal therapy. There are approaches used by clinicians, and they can be social workers, can be psychologists, and some psychiatrists, of course, do that as well. And those are effective treatments for depression. The thing is, it takes longer compared to medication. And sadly, it's more expensive, not always covered to the degree you would like by insurance companies. I don't want to minimize the importance of lifestyle modifications. Exercising, there have been tons and tons of publications to show the effect of exercise on mood. And it's not because we just feel better about our bodies because we move or because we lost weight and we look better. There are outright very, very clear changes in the brain that we can see through sophisticated imaging, again, in areas of mood as a result of exercising. Meditation, yoga, relaxation techniques, dietary changes. Those things are very, very important in treating depression and should be included in the package when a clinician talks to a patient who comes to their office. And this is just an example of the dietary effects on cell growth. Again, it's very important. When I went to medical school, which was quite long ago, we learned, you know, you're born with a number of neurons in the brain cells, and that's what you will have. What will happen over time? You'll just lose them with aging. That's not true anymore. That's what I learned in medical school in the early 80s. We know that brain cells do regenerate. And there are things that can help it or things that can make it worse. Inflammation is not good. Antioxidants are good. So this is very important to think also about the whole package, including diet. But, and this is the reason we're here, what happens if the treatment doesn't work? A doctor starts somebody on an antidepressant and the person does not improve or doesn't improve enough. They come to the doctor and say, you know, I'm kind of a little better. I think I am better. That's very often we would hear. I guess I feel somewhat better, but still things are not really looking up. Then what? And this is when we come to the issue of treatment-resistant depression. So first of all, what is treatment-resistant depression? Or we find names for everything. We call it TRD. And there are a number of definitions of what constitutes treatment-resistant depression. And really, for a person who suffers, it doesn't really matter. We, as clinicians and researchers, just sit and argue what exactly the definition should be. And there are a number of them, and we still don't agree exactly. Some are used in research that may be more stringent. Some are a little bit more loose when it comes to clinical approach. But more or less the consensus nowadays is that treatment-resistant depression is one where at least two unsuccessful trials of adequate antidepressant treatment, mostly medications, were given. So now the question is, okay, 2 treatments, fine. What's adequate? Adequate means that the doctor tried to give good enough dose, and we've seen time and time again that the doses that are given very often are not sufficient, are not the optimal ones. So the adequate would mean that the dose is appropriate and the length of time is appropriate. Very often people would come to us and say, you know, my primary care doc gave me a 30-day supply of medication. I took it, nothing happened, so I stopped it. 30 days, 4 weeks. It's not, per definition of what we look at treatment-resistant depression, the minimum of treatment should be 8 weeks. And I'm not saying that it's easy to achieve, because people suffer. And when you decide you're gonna start treatment, you really want to see results, and you want to see them relatively fast, because you've been going with and living with depression for quite some time. You suddenly finally decide to do something about it. You got the treatment, a month passes, not much happens. Why should I continue? But one should. What does it mean unsuccessful? So you took the dose that you're supposed to, you took it for long enough. What does it mean unsuccessful treatment? Usually we try to say that people would still continue complaining of having less than 50% improvement. And it's really eyeballing. It's what you feel. You feel that you're better, but not even less than halfway there. And that's what would mean TRD, or treatment-resistant depression. Now, why people don't respond to treatment? We have pretty good medications, but you saw the numbers. They're not amazing. So there are a couple of reasons that we think contribute to lack of response. One of them is that the delay to receive treatment in their first episode. So if the later you start treating your depression, when it starts, the worse it is. Having other psychiatric conditions that go along with your depression. Again, I've mentioned anxiety, people who have post-traumatic stress disorder, obsessive compulsive disorder, what we call comorbidity. Having additional disorder makes it much harder to treat the depression. Medical condition, pain, heart problems, neurological conditions make treatment of depression more difficult. Stress, stressful life events, pandemic, job loss, losses make treating depression harder. How severe the depression is also predicts the response. So the more severe the depression, the harder it is to treat. Kind of makes sense. Very early onset of depression, just in terms of lifespan, may be a predictor of worse response. So if a person comes to us and the first episode happened, let's say in the 50s, in their 50s or 60s, not in early adulthood or childhood, the probability of responding is better than when it happens very early. And of course, again, it seems so obvious, but it's important to very high level of suicidality with the depressive episode make it harder to treat. Now, as I mentioned, why is it so important? Why it becomes such a serious problem when depression cannot be treated effectively, when people have resistance to treatment? Because it happens in pretty high rates, as I mentioned. It's thought that TRD affects between 50 to 60% of patients. I'm talking about those who are treated. And unfortunately, the more serious the depression and that we cannot bring down, we cannot bring to remission, increases the risk of suicide attempts. And this is really why is it so critically important to learn and be able to effectively treat those more difficult cases. So what should we do? Now you can hear me again. So, so how should we approach treatment-resistant depression? And it's not only we as doctor, but again, we as consumers. First of all, the clinician has to check that the treatment is appropriate. And again, I will touch on it in a second in a little bit more detail, but the idea is, one, that this is the right treatment, the right duration, the right dosing. Very often, people have side effects. And if they have side effects, they don't take it long enough. They don't take the right dose. They don't take it on a continuous basis. They will take it one day and maybe not the other. And it also doesn't make you feel good if you have, let's say, nausea, or if you have diarrhea, or if you feel really crappy from the medication. That's not really a predictor of really feeling great, because it's something that you have to take for a long time. I say it to younger psychiatrists and residents over and over again. Don't forget the other conditions. Don't overlook other complaints. Again, anxiety. If there is underlying substance abuse, don't forget to ask. Don't forget to inquire, particularly if people continue complaining that they have depression. Very often, very well-meaning doctors, busy and overworked, will give the medication, the right medication, but you need to sit and talk and see what else is going on. What's happening in person's life. Stressors, as I said, are predictors of lower response. We have to look at those and help patients work on reducing those stressors, or how they deal with the stressors. I mean, some things are inevitable. We can change the pandemic, but there are strategies and techniques that it is so important that clinicians should talk with patients about and instruct them what to do. We as clinicians have to look if there are just drug interactions. Some of them may affect the dosing of the medication. One can lower the dose of the other, or vice versa. We have to look at drug-drug interactions. That's our job. And at some point, we have to sit, put our thinking hats on again and say, is it depression? Maybe it's something else. Maybe it's a bipolar depression. We have to sit and reevaluate. It takes time. It takes some thinking, but it's very important. And maybe the question to ask, doctor, is there anything you think, anything else is going on? This is upon us to reevaluate if the original diagnosis was correct. Did we overlook something? And it happens that we do. All right, so what do we do? As I've mentioned, we try to improve the initial treatment. And it happens so often that we see even people who come as we deal with patients in research setting only, but when they come to us and we do research in treatment-resistant depression, Shelby and Allison, who are on this call, we work together. When they talk to these people, the first question is, what's the dose of the medication you have taken? How long did you take it for? And we're discovering all kinds of interesting things. Again, half the dose, not enough time, not because the person didn't want to do that, but very often, again, the initial prescription was starting dose and it never went anywhere. So once we do that and we improve the initial treatment, that's the beginning of our journey as a clinician who deal with TRD. Then we can add an approved treatment, usually again a medication, a booster. We can combine two different antidepressants together that do different things. Not all of them, again, are from the same group or affect the brain the same way. So one technique is for us to combine different antidepressants. We can also go and switch to another antidepressant that is from a completely different family of chemicals. we can switch to less common medications, not just another antidepressant, and we can touch on those, and you will see in a second. Or again, in more and more research has been done in other approaches that are not necessarily medications, that are novel, and some of them are more invasive. And again, the route to these more invasive therapies, you start with the easiest and more palatable to the clinician and the patient in particular, and then work your way down. So what are those add-on different medications? So there are a number of FDA approved treatments that are specifically approved for treatment-resistant depression. So for example, those antipsychotic medications I mentioned that are used in general regionally for hallucinations, delusions, for people with schizophrenia or psychotic bipolar conditions, this newer generation of some of these antipsychotics are effective and have been tested and have been studied in controlled trials and approved by the FDA to add to treatment of antidepressants to boost the antidepressant. We call it augmentation. And those are, the names may seem familiar to some of you. One of them is Abilify. There is another one, the non-generic, the name is Resulti. There is Quetiapine, Seroquel. There was also, and it's been around for quite some time, there's another company that just what they did, they took fluoxetine, which is Prozac, and added olanzapine, which is an antipsychotic, made it into one drug. It's another trick that companies do, and made one medication out of it, indicated for treatment-resistant depression. Now, non-medication, non-antidepressant or oral medication or approaches include electroconvulsive therapy. We'll again touch on what happens nowadays with ECT. There is another approach that some of you may be familiar with called transcranial magnetic stimulation, TMS, and those are all FDA approved for treatment-resistant depression. It's not that they're just out there. There's a very specific FDA indication for these approaches. The new kid on the block, for lack of a better word, is esketamine or ketamines. It's the one that came from, the only one available on the market that is indicated for TRD is nasal spray. It's called esketamine. It's a kind of a version of what's ketamine. Again, I'll describe it in a second. It's called Spravato. It's made by Johnson & Johnson. It's the newest addition, again, indicated for treatment-resistant depression. There is an interesting device called VNS, vagal nerve stimulation, that I'll show you in a second, which is also kind of an innovative approach to treating treatment-resistant depression. And there are kind of a little bit more of the big guns, shall we say. So let's talk about these bigger guns. So, ECT, electroconvulsive therapy, has been around for a long time. We know it is effective procedure for many treatment-resistant mood disorder patients. It's not by all means perfect. That's the reason we always look for alternatives. But the modern ECT is considerably different than the one that we used to call in the old days, and not so old days, shock treatments, portrayed very negatively in movies and popular literature. And they were not a pretty picture originally in terms of what you see and the experience of patients. But right now, ECT does not involve convulsions per se. Patients get muscle relaxant and are under anesthesia. There are no pads on the head. There's this little picture that I included, not for the fun, but it's actually how it will look. There are soft electrode kind of patches placed on the face and a temple. And patients typically receive around 7 treatments. They're spaced over a period of several weeks. And there is research also showing an approval to use it as kind of a maintenance therapy after the initial course. But there are issues with ECT. despite placing the electrodes, in a certain way, and the new ways of, the more gentle way of administering ECT, there's still some side effects, some changes in memory. Things should improve over time following ECT, but we still have some reluctance on the part of patients, and we also always look for better tolerated and less invasive approaches. But I have to stress again, it's very effective. So the alternative that people started a number of years ago now looking at, and it has been approved for several years, is the transcranial magnetic stimulation, which is what the little picture shows here, which is a use of magnetic stimulation that is placed kind of device, or it almost seems like a dentist chair that the person sits in. It's applying the magnetic current on the outside of the head that penetrates through the skull into brain areas. And again, it's the placement of it is very important, because you want to target areas that are responsible for mood. And through this magnetic field, it stimulates those brain areas, and those impulses affect brain cells, increase the specific areas and the activity of those areas, and does relieve depression. Those sessions don't last very long. Again, there's no need for anesthesia or anything. You're just almost sitting like a dental chair. And when we started doing them years ago, it's been used in other fields in neurology. You can put it in an area that stimulates the motor area. And I remember I volunteered to sit in a chair, and our colleagues at MUSC stimulated one area of my brain, and my hand jumped. And so it's used in neurology as well. But so the sessions are not very long, 20 to 40 minutes. The treatments are quite taxing time-wise, time investment, because you have to do it, and it depends. Some approaches are that you're doing it daily, 5 days a week for 4 to 6 weeks, or you do it daily, 5 days a week over 3 weeks period, and then 3 times a week for several weeks thereafter. The idea is to get to a number of treatments, and they are ranging, depends on the school of thought, and somewhere between 30 to close to 40 treatments. So that's how you do them, and they really have to be done quite intensive time schedule. Again, you're awake, side effects are very minor, and it's clearly much easier to administer. Now, again, the new kid on the block is the use of ketamine. So originally, if you recall, ketamine is an anesthesia drug. It's also a drug of abuse. It can create hallucinations, kind of dissociative feeling. There are reasons why it helps, and helps quickly with alleviating depression. So originally it started with doing it as an infusion, although it does not have an approval by the FDA as infusion, which is difficult to administer, and again, the issues of side effects and were problematic, and a pharmaceutical company, and side effects, of course, and the pharmaceutical company, Johnson & Johnson, came up with what we call a metabolite. So it's a version of ketamine called Esketamine that they developed to use as a nasal spray. Now it's not, the nasal spray that you use, when you have allergies or some kind of a minor condition that you self-administer. It is a very potent drug with potential for significant side effects. Therefore, it has to be administered in medical facility by a clinician. It cannot be a prescription that you take home. It is approved to use in conjunction with other antidepressants. It's given twice a week for several weeks. And again, as I've mentioned, it's something that has to be done under supervision of a clinician. Now, the last one that has been approved treatment for TRD is what I call vagal nerve stimulation, or VNS. And this is kind of an interesting approach. It's almost like a placing pacemaker that you implant under a skin with electrodes that are stimulating what we call the vagal nerve. Vagal nerve is a very long nerve that goes up to the brain. And this kind of a pacemaker sends impulses through the vagal nerve that stimulates brain areas, again, where we think mood areas are located. And through that kind of a pulse administration, for a number of reasons that I'm not gonna bore you with, it affects the specific nerve cells and affects mood. It is approved for TRD, chronic, hard to treat. Really, the threshold for who is the right person for such treatment is pretty high, because again, it's an invasive, you implant something in the body. So the criteria are even more stringent than we have for TRD. If somebody hasn't improved after trying at least 4 or more medications, or ECT, or both, those people would be candidates for the implant for VNS. This is done also in conjunction of taking antidepressant treatment of oral medications. There is one last thing that I wanted to show you, which is an experimental treatment. It's not on the market. It's to replace ECT. There are studies looking and using, again, magnetic stimulation for induction of seizures, kind of a la ECT, to replace ECT because it is better tolerated with fewer cognitive side effects that we are trying to really eliminate from the ECT gestalt. So this is something that you may hear about in the future. Now, last area, and it's important and to us and to me personally and to the field of people who deal with treatment-resistant depression. Here is the problem. Nobody really studied until pretty much now what's the best approach. So I said, there are those different things that we can do, but which one is better? There was no head-to-head comparison of looking, okay, should we switch to a different treatment? Should we add? Or should we do something different altogether? Interestingly enough, the field did not go to do a study until now, until 2 years ago, to compare head-to-head the different approaches. So everybody kind of decides logically, there are algorithms, but kind of on their own, based on their experience and their preference. Why those studies were not done before? Because a lot of it is about money. Many of these medications, as I told you, are generic by now. There are many treatments. Those are very expensive studies to do because you have to have several groups that you study simultaneously. So those expensive studies require quite a bit of people. Pharmaceutical companies, that's where the medications are and the money is, very often have no appetite for those. So it has to come from either federal government or nonprofit entities. And the decision was made several years ago. We have to really figure out what do we tell clinicians as a field? What's the best approach? And this is where our work comes into play. It was 2 years ago, I want to say, very large grant was awarded to the field through Mass General, through Harvard Medical School, to do a very large trial that compares the different approaches. Switching to a different medication, adding another medication, or doing an approved, well-tolerated treatment like transmagnetic stimulation. This is called Ascertain Trial, Comparative Effectiveness Research Trial for Antidepressant Incomplete and Non-Responders with Treatment-Resistant Depression. It's a federal grant, so the studies are usually quite long. I think it is in its second or third year. It probably will go longer on because of the interruption that we had due to COVID. And one of the reasons we had an interruption due to COVID, because one of the treatment arms, as I mentioned, involves transmagnetic stimulation. We couldn't bring people to the office. Nowhere in the country. It's done across the country. And I think it's really important question to answer. And I think important for people to know about, and if, of course, they're interested to participate. None of the research that we conduct or other sites as well is at any cost to people. Interestingly enough, these type of studies don't need to involve what we call placebo, which is what we call sugar or sham peer, because we really want to learn in real life people with treatment-resistant depression what's the best approach. So we do not really need to involve what we call pill placebo, because we know that these medications in general work. They have been all approved treatments. So this is what we're doing. You can learn more about any treatment for depression or any clinical research actually in any area, but this particularly is, of course, dear and important to us, because I think it has to be done and answer this question. There is a website called clinicaltrials.gov that every research that is done, not necessarily with medications, has to be registered, and details are there about each project. And of course, Ascertain Trial is on clinicaltrials.gov. What we also do, because I think it's a very important service, and it helps us also sort out what's going on, is that we do conduct free depression assessments for people who complain, in particular, that do not respond to treatment. And they can be done virtually. And this is our information with my dear colleagues Allison and Shelby's contact information and phone number. One, to ask questions of us, see if you want to be evaluated, or any other ways we can help with. That's really concluding my presentation to you all. I think it's it's close to 8. I don't want to take too much more, any more of your time than necessary, but I really welcome questions, comments.
I had a couple of questions. So with the, well, for one thing, it seems like the percent, or the 16.6 prevalence for depression, it seems like it should be much higher than that. It seems like a lot more people have depression than
well, correct. This is an epidemiological trial. It does, those are epidemiological trials done in the US. They don't include children. Those are adults, and they're not geriatric adults. So it's usually 18 to 64 or so. So this excludes quite a bit of population. I just wanted to give people a feel. Actually, that's a lot, when you think about it, because these are people who meet the criteria. It's not people who feel depressed or are mildly depressed. These are people who meet criteria. And for the most part, these people have more than 2 weeks length of depression. So this is kind of a general number. You can probably see some that go up to 18. Again, this is an adult population, so it's not geriatric, nor is it pediatric population. And again, yes, go ahead.
Sorry. And that brought up another question. The type of treatments, sometimes does age depend upon that? Like, for example, do teens qualify for TMS? Because I know like some teens, if they take certain antidepressants, it's been found that it will make it worse. Are there, alternative treatments that they can do that? I was just curious if that had been.
So you're right. So for antidepressants, it's a very good question. I'm not a pediatric expert, but I believe the TMS, it's not limited to adults only. Regarding antidepressants, the answer is it's not exclusionary for children to use antidepressants. That being said, there is what we call a black box and a warning about the use of antidepressants in younger people. The reason and how it happened, I think the data started coming up early 2000, late 90s, when we started seeing increase in suicidal thoughts, not necessarily suicide attempts, in younger or teenagers and children who were on antidepressants. And there were many thoughts, why on earth younger people, and this is up to age of, I think, 21, that we consider the younger population. And we didn't see it in older adults. We've seen it in younger population. We're trying to understand why the increase in suicidal ideation in younger people. Some thoughts were what happens when you start taking antidepressant, what comes back first, it's not necessarily the improvement in mood, but the physical symptoms. So for example, you have more energy. You can still be dysphoric and feeling down, but you have more energy, more ability to plan. And this kind of a disconnect can lead, with the thoughts, makes it much more dangerous. So people still feel down, but they have the energy. I'm not saying that people are so withdrawn that they don't have the energy to commit suicide, but increased energy with feeling really bad or being somewhat more agitated is fairly bad combination that was one of the explanation for why in pediatric or younger population we don't see it in older adults. And we just have to keep an eye on it. It's very important. We cannot, as I showed before, if there is a depression, diagnosable condition, we have to start treating it, because delaying treatment is not good either. But it is a black box for antidepressants, and requirement to be very, very careful and follow younger people very, very closely.
And I had a couple more questions and then I'll open it up. Have there ever been any like comparison studies or brain scans to show people who seem to be more resilient and don't, fall into depression, or, like they may have the same tragedies happen that other people do, but they don't become depressed long-term like others. I was just curious if there was like a comparison. I didn't know if there was any studies like related to that.
So there was research including looking at changes, actually some genetic changes, looking at, for example, early childhood trauma. And we know that early childhood trauma, like abuse, does affect certain brain area size, literally. And in combination with some genetic changes in serotonergic system, increases the risk for depression. So there are many studies being done now, interestingly enough, a number of them in young soldiers, looking at these resiliency factors to look, and there are factors that are inborn resiliency factors, but they're also learned and environmental. So it's not that you're born resilient. I mean, if you're not, you're doomed. But there are inborn, inherent factors that constitute improved resiliency that may help also with how you react to stressors. And a lot of the research is actually done in post-traumatic stress disorder. You know, what constitutes resiliency, you know, why some people after traumatic event have PTSD and some don't. So that's the same type of research. But there is a threshold. I mean, for example, in stressors, on early childhood stressor, there is so much than the body and the system can take. So it gets to the certain level, particularly in early childhood stress, that the depression becomes a very significant risk.
And my last question, then I'll let others ask, but will there ever be a time, in your opinion, where people could potentially choose something like TMS versus medication? Because, you know, sometimes with medication, like you were mentioning, it doesn't seem to have the same effect. Like with TMS, I've heard that someone can get the treatment and their condition will improve, like they'll be better for a whole year before they might need another treatment. And sometimes it's even longer than that. But with medication, you have to take it every day and you can have like different side effects and things. So I just wondered if there'll ever be that choice for people where if they don't, because some people don't like taking medication at all.
Correct. But for the most part, again, the TMS is also used in conjunction with antidepressants. We don't stop antidepressants when people do TMS. So would you say that this treatment it's not strong enough? These are just yes. And for example, you know, I think that you know, it's hard to go back to the old ECT, but we know it's a powerful treatment, you know, and if you can go on maintenance that is not a daily use, and yes, you can do very well for prolonged periods of time. So no, it doesn't mean that medication is the panacea. And really, in the field, we are struggling with the idea that, you know, and then not only that, some people would say, well, you're piling medication on people one after another, because we don't have that perfect response to one thing. And the reason is because it's that cone that I've showed you in this funky slide. We know quite a bit about depression, but I think not enough. It's not a one thing. It's not one factor. I think with more genetic research in not only the genes but the downstream, you know, what we call proteomics, which goes from learning more about the products that get created as a function of genes. We are learning more, but frankly, we are not there yet to say that there is one solution, and that's the problem. And that's really what's disappointing after so many years. Prozac came on the market so many years ago, I think in the late 80s, was the first kind of a game-changing antidepressant, fairly well tolerated, etc. And here we are 30-some or 40 years later, and we don't have the solution. But we are in much better shape that we can sit now and look at, you know, changing the threshold of how far we want to go. First, there was some response. Now we said the response is not good enough. But I don't think with the various factors. Now we're looking at inflammation, for example, as a reason and working in depression. So it's another completely different approach and game changer. We really don't have one unifying theory. This is the one thing, and therefore then we can have one treatment that will do it all. And in most medical conditions, this is not how it works. It doesn't work like this in cardiology. It doesn't work like this in cancer treatment. We looked at algorithms and approach of more than one thing. We do not have one unifying drug for each condition. Unfortunately, depression is no different. So where we be at the point that, we can say maybe when we got to the point that we really can pinpoint, and there is no one area, but really pinpoint several offenders and then create that one treatment. It would be nice if you can just implant and, like the VNS implant, a kind of a pacemaker that will deliver the stimulation, and here we go. I don't anticipate that type of a, eureka aha moment in our field that goes kind of, stepwise. We just kind of plateaued and some change happens in the basic science research, and then we clinicians step in. I don't anticipate that kind of a panacea happening anytime soon.
I was hoping by now we would have those scanners like they have in Star Trek. And
yes, every time, you do, I go to a GI doctor and I'm thinking to myself, gastroenterology, we can fly to the moon. Wouldn't it be great that you don't have to, that you can have a very easy approach to taking pictures of your colon, and you have to do all these various funny things. I don't want to be, I am optimistic because I think that now that we can visualize and combine not only how brain areas look, but we can see how they work. There are some what we call resting state fMRI. It's a way for us to look how information travels from one brain area to another, how brain areas communicate, combined with genetic in what we call biological markers, blood markers. I think we've made amazing progress, but as you've seen, we're not there yet.
Does anyone else have any questions? Do you have like a few more minutes, Dr. Mintzer?
My cats are not in my room yet, so yes.
Okay.
But they're meowing outside, but yes, please, be happy to answer.
This is Sarah Canson. My son was born with a mental illness, so I would venture to say that I'm calling him clinically frustrated, because he can't get to where he wants to be ever because of his high aspirations, meaning that everything has to be 100%. So one of the things I did was, Dr. Turner, who's the neuropathologist, came to our meeting, and so Neil went through one of his sessions, and it allowed his brain to be more focused, and now I'm continuing it. But what it's going after is the portions of the brain that are causing are the most agitated in life, and hopefully through newer pathway, at least it can attenuate some of that activity to the point where he's not as frustrated as he is. Is there anything that in that sphere of that neural pathway therapy that helps depression?
Again, first of all, brain is a very complicated machine. So, different and as I mentioned, there are just a lot of different variables that come into play to create something that we call a syndrome, because this is what depression is really a combo of symptoms. Mm-hmm. And that maybe one day we will learn that they're just a basket in a way of conditions. But yes, there is I think that the field is moving towards when we can start really with modeling, and as I said, even things like resting state fMRI, learning how information travels within the brain, the areas of brain, how they communicate with each other. We know that there is a plasticity, and you can train those brain areas, not with medications. We learn about those things in other areas, such as dementia. You can do. I was just in a virtual meeting looking at in dementia of brain training, not through games and doing puzzles, but very specific training that while you're doing brain imaging, you can see which areas you activate and how they communicate with another area. So it doesn't have to be medication necessarily. I do believe that we can get, maybe with the help of AI, to create non-pharmacological approaches to retrain in the connectivity between various brain areas, to decrease overactivity in one area, as you said, that creates frustration, and others that creates dysphoric moods. But again, it's very complicated. Also, I think it's a whole different conversation to be had. That you mentioned the particular, personal case is of secondary effects of having certain symptoms like frustration, and learning whether any issues with learning patterns that can create frustration, or maybe particular certain areas of personality or symptomatic kind of rigidity that prevents some flexibility, which again, all these things can be trained, and there is no pill for that. So the answer is yes, even in mood areas, we're looking at trying to retrain in a much more sophisticated way brain areas that are talking to each other and affecting mood.
I appreciate the information, and it was just so exciting to hear about the advances in the field and the work that you specifically are doing. It's can't wait to see what comes out of that.
Well, thank you very much, and thank you for indulging me and helping me with even